The host of the SCAI Bifurcation Club webinar series. These topics to discuss today are strategies in bifurcation and in-stent restenosis. This is sponsored by SCAI. Next slide, please. So the moderators are Doctors Kevin Croce from Brigham and Ron Waxman from Washington Hospital Center. And Ron started this a long time ago with Dr. King and really was one of the pioneers in ISR in this country. Our panelists will be Dr. Schlafmitz from San Francisco, New York, and John Lisco. Case presenters are Pratik Sandisara from Emory, Khalid Al-Mary from Kuwait City, and Kevin Croce from Brigham and Women's. So I'll pass it on to Kevin to start moderating the session. One more thing, there are no disclosures. This is supported by a grant from Medtronic. Next, please. And you can get CME with 1 hour AMA credit through my course in SCAI. So take it on, Kevin. Thank you.
Great. Thanks, Tanvir. We're excited to be here tonight with a host of faculties who have extreme expertise in in-stent restenosis. You know, I was excited when Tanvir and the team asked us to present on this topic because in-stent restenosis is a problem in and of itself that, as we know, can be recalcitrant in patients and can be difficult to treat in a durable fashion. It's particularly complicated when it involves bifurcations. And as you know, one of the problems with bifurcation stenting is that we have higher rates of TLR related to in-stent restenosis. And so I think, upfront imaging and doing a good job to get your first stent in well should be the edict, but that doesn't always lead to good results despite best efforts in modern practice. And so you've got 3 case presenters today. We've got an expert faculty, including, as Tanvir mentioned, Ron Waxman, who's really been a pioneer in treating in-stent restenosis for many years now, and I've learned a lot from Ron, who I'm co-moderating with. So the lineup today is we're going to start with Dr. Sandisara, who's with us from a trip in Minnesota on his way back to Emory. And then at the end of the session, Dr. Lisco, who's Dr. Sandisara's partner, is going to talk about their efforts to set up a focused ISR clinic to help treat patients that are afflicted with this problem. And so without further ado, we'll try to keep this conversational. And Pratik, go ahead and take it away. I think you're muted, Pratik.
Great. Thanks so much, Kevin. And thank you, Dr. Rab and SCAI, for this opportunity to present. It's great to be here with a very esteemed group of colleagues. So I'll start off with a case here of an 80-year-old male. He presented with class 3 angina, past medical history of CAD, had a PCI of the LAD diag bifurcation in 2021, history of hypertension, hyperlipidemia. He had a SPECT which showed anterior ischemia and has normal ejection fraction on echocardiogram. This led to a cardiac catheterization, which basically showed, I just have one image here of the problem area. You can see there's a stent extending from the prox to mid-LAD along with the bifurcation diag stent. And then if you look on the still image here on the right, so you can see severe ISR here in the ocular diag. This is actually a distal edge of the LAD stent. There's a gap, and then there's another stent further downstream in the mid-LAD. And, so we have a very algorithmic approach, which is image-guided for management of ISR. And so for this, we pre-dilated both the LAD and diagonal branches with a 2.5 NC, which was followed by IVUS imaging. And here's the IVUS pullback from the LAD. So you saw that distal stent, and there's a gap here in between 2 stents, and you'll see some dropout with some de novo disease in between the 2 stents, which leads into severe neonatal hyperplasia at the distal edge of the old stent. Here's the diagonal branch coming in at 10 o'clock. And then you see again more neonatal hyperplasia and in-stent restenosis in that LAD segment proximal to the diagonal branch. And we're continuing the pullback all the way back to the proximal LAD. You see some calcific neoathero as well as some underexpansion in that proximal segment of the LAD stent. So I have some reference numbers on the right-hand side. So the distal vessel is 2.5 millimeters in diameter and a reference of 4.94 millimeters squared. The MSA was 1.96, and that's marked out on the right-hand side here, just proximal to the takeoff of the diagonal branch. And then I have some other still images of the new lesion distal to the mid-LED stent in that area, in the gap area, and then the distal reference segment at the very bottom right-hand panel in the distal stent. So, this is, and I'll let this IVUS run from the diagonal branch again. Basically, we're pulling back distal to proximal. You'll see the stent's well expanded. You see a significant amount of neonatal hyperplasia right here as we're coming back into the LAD, coming in from your 1, 2 o'clock. And then you can see that, again, the disease in the LAD just proximal to the takeoff of the diagonal branch there. Again, pull back all the way back to the prox LAD and left lobe. So from a diagonal branch standpoint, the distal reference diameter was 2.5 millimeters with an area of 3.32 millimeters squared. And the MSA was 1.62, which is marked with the area of severe ISR that you can see angiographically on the right-hand panel. So, Kevin, I'll pause here if there are any comments from the panelists about thoughts on how to approach this.
So one clarification, this is first time ISR, we had only one layer, is that correct?
Yes, just one layer.
Yeah, I think you nicely outline in product. There's a couple different mechanisms of action here, probably to some degree undersizing, correct? And then additional to that, there's tissue inside the stents, some of which is more benign looking neointimal tissue. And there's some evidence of calcific neoatherosclerosis, correct?
Yes,
So
exactly.
It's a potpourri of ISR mechanism, which is quite nice.
Yeah, exactly.
Yeah, awesome.
What are your thoughts? I guess, how you'd start off.
Yeah, the hard part about calcific neoathero is that, there's really no place for it to go. So outside of the sizing issues of the stent, you kind of have a compliance in a bulky tissue with no home to go as you start to stretch this thing. And so a lot of times, we're inclined to either use some sort of plaque modification. There is potentially a value play here to softening everything up with IVL, including the neointimal tissue, to see if you can get an adequate MSA on expansion in the calcified neoathero segment. And if you can't, it's one of those scenarios where sometimes we just need to go ahead and drill it with a rotabur or with orbital. Admittedly, orbital is contraindicated, but it does work quite well with debulking calcific neoathero. The amount of calcific neoathero in this case isn't so awful product that I might not try, some IVL massage therapy, see if you could make things bigger. I'd be loving to not have to re-bifurcation stent this. And so I'd be interested, what Evan thinks, but if there's a way to get this open to a place where, at worst you have to stent the LED main branch, but DCB out the diagonal in some way. And a lot of the decisions of what your final therapy is really going to be driven by how much recoil, what sustainable MSA you gain based on doing ballooning, plaque modification, whatever you decide to do. Be interested, Evan, Ron, or college. You guys have any other thoughts?
Yeah, no.
Yeah, if I may chime in for a second, this is interesting because it's not only ISR, it's including also a segment that was never stented, which does have, it didn't come into our classification. We have, biological, mechanical, mixed, neoathero, all those A, B, C, D. But this one is also including a segment in between that never been stented. So that may change the approach. And I agree with you that there is a modest neoathero. So, and I think that you definitely don't want to restent the diagonal. So my approach would be to wire both, to do just POBA, try to get the best imaging guided outcome just with balloon, then to go with DCB to the diagonal, and to finalize with restenting the LAD, including the unstented segment. I think that probably would be the best approach in this situation. Now, should we don't feel that the balloon is fully adequate, I would apply all the other modalities that you have suggested.
Great thoughts and comments from everyone, and yeah, that was our thought as well. And Kevin, as you said, yes, there is some calcific neoathero, but I felt like it's not really really too overwhelming, and I thought there's a ton of neointimal tissue. So basically, my thought process was to maybe start off with laser for the neointimal hyperplasia. After we just did 2.5 NC to kind of open up some room for the IVUS. So we did laser with saline for both 1,4 fiber on both the diag and the LAD. And then this was followed by just Wolverine cutting balloon for 2.5 in the diagonal branch, 3.0 in the LAD, and then 3.5 in the entire prox LAD segment proximal to the diagonal branch.
It's a nice picture in the middle there, product. I always it piques my interest when the Wolverine's up at a reasonable pressure, and there still seems to be a space between the stent metal and the balloon itself. You kind of like you see that you've got some tissue there, and it's just a matter of whether that stuff compresses and stays compressed or is going to expand well. But I think your approach to debulk is a good one. The way you overcome this problem is by stretching the underexpanded stents and making them huge and getting acute luminal gain that makes the final kind of tissue that's left behind maybe not be that bad from a % diameter stenosis. But your thoughts to remove some of it with a laser is good, especially, it doesn't do that well for debulking calcific neoathero, but it can help with, more rubbery stuff. And so that's a nice application of the technology from a mechanistic standpoint here.
Also,
sorry, go ahead.
I was just going to add with the cutting, it's a lot of things. In addition, just from plaque modification in the areas, if you're considering DEB, I really find that it's helpful theoretically, just from greater drug delivery. But you also learn, as Kevin mentioned, so much about, are you ready for the next step, be it drug-coated balloon or another drug-coated stent, based on that expansion. And you can see it here even on just the gap between the prior stent and the cutting balloon in the middle image. With any of the advanced fluoro, things like device detection, stent boost, you can really hone in on that, particularly for bifurcation lesions. It's great, just so you can see how you're getting expansion. But one thing, just to your credit with the IVUS before, just because one of the focus of the session's bifurcation is because you so nicely did IVUS from both arms, the LAD and the diag, you see it was a perfect bifurcation. You see two perfect ostia. There was that one image that kept looping where the ostia was, the implant, like that's perfect. It is a perfect double barrel. So I think it's so helpful having that image and really understanding that you don't need to put another double layer of stent across this, particularly in the diag. And I think, agreeing with what the others said, hopefully just, if you get good expansion, drug-coated balloon for the diag, and then really focusing in on the LAD.
Great points. And, so Kevin, I see what you're saying with the gap there in the middle panel. And, I hit that area actually. It's just proximal to the diag with a 3.5. And and then, we talked about that gap. So my thought was maybe treat that middle segment with a short stent, not crossing the diag. And so I put a 2.5/18 DES in that middle segment to treat the de novo disease, post dilated, and you can see really good expansion here on the image. And so, the question now is, are we ready to do DCB or brachy? And so, we went ahead with the KISS just to make sure we're conforming the carina, the bifurcation, and then here's the image angiographically after treating that distal de novo disease, kissing balloon inflation, cutting balloon, and laser.
Yeah, the one nice thing about a cutting balloon product is, I don't know that this has been proven, but one of the main problems with rubbery new animal tissue is recoil, and it can happen, it can look okay initially, and then you get to take your final angiogram, and this stuff sort of bounces back at you over time.
Yes.
I think Jeff Potmel once pointed out that Roxana, I wouldn't be surprised if Ron was a co-author back then, had a paper in Circ apparently that wasn't In-Stent restenosis. It was In-Stent, A-A-N-T, because like they brought a patient back for a relook and the angiogram looked good at the end of the case, and 2 hours later it had sort of recoiled back. And so the nice thing about a cutting balloon is I hope when I use it in these scenarios that by the fact you're slicing the neointima, you're creating some discontinuities in that tissue, which just hopefully separates it a little bit, that the fibers are a little less likely to recoil back at you. And so having defined what was inside the stent with the initial IVUS is super important, because I think you employed 2 technologies in sequence: laser to hopefully debulk, and maybe soften a little bit. Softens better when you use contrast, but then a cutting balloon to mitigate hopefully a little bit of the recoil, which can be prone in these cases. And you did 1-to-1 sizing based on the IVUS, which is nice. And at least your initial picture there looks like, substantial recoil is not a major problem right now. You've got a reasonable angiographic result here. And so I'd be hoping like, oh, maybe this can be a kissing DCB or a DCB case, and I don't have to restent the part of the LED that involves the diagonal. But, your use of imaging, and I think choice of device based on it has been really nice thus far.
Hey, Kevin, how does imaging up front affect your choice of cutting balloon technology, be it with a Sculpt or a Wolverine?
Yeah, so I think it boils down to a couple things. I'll show a little bit of the algorithm that Evan and I developed a couple of years back related to my case. But the main question is the stent well sized or well expanded or not? And if it's big, what's inside of it? What is that tissue made of? And so if it's under expanded in focal, I'll usually use a Sculpt, because you can crank on them to 25, 28, and they typically are rupture resistant and stay put. And if it's new animal tissue that I'm worried is going to recoil, I'll take a Wolverine to try to slice it so it's a little less likely to be connected and come back at me. I mean, that's sort of a back of the napkin approach I have, but all of it's driven based on what the IVUS or OCT tells you inside the stent, and whether the IVUS or OCT tells you the stent is expanded or not.
And
I want to make a comment here on the In-Stent restenosis. I think that even with cutting balloon, you're going to have the tissue falling back.
Yeah.
And you're not going to prevent it. So the only trick is really to use antiproliferative technology, which could be obviously drug-eluting stent, which we would try not to. We use brachytherapy a lot. And when you use brachytherapy, the tissue will disappear. So you don't have to worry what's going to happen the next 24 hours. If you're using just POBA, you have to worry. But if you use DCB, it can work like brachytherapy. So I think DCB, both arms, post, will take care of the tissue over time, and you don't have to push too much, eliminate the tissue, because you're not eliminating it. It's going to fall back. And again, it's just a question, maybe another 30 minutes, another 1 hour. If you'll wait, you'll see the tissue coming.
Yeah, we see that in brachy cases, right, Ron? The angiogram looks good. You call for the brachy guy or gal. They come from wherever they are. They do their timeout. You prep the catheter. You put the catheter in. You keep the catheter for 10 minutes if you're doing 212s, maybe a little bit longer. And then like your final picture looks awful again. I find it very frustrating. So we see
exactly, but you should not react to that.
Yep.
The key issue is not to react, because people used to react to that.
Yeah, the one thing product that I think the data shows, at least observationally for
Do
age,
more and more and more. And really what's you need to be, if it's not obstructive.
I think Ron's audio is in and out. But anyway, so you've got a reasonable angiographic result there. It looks nice product. What'd you do next?
Well, so I IVUS both limbs just to, see how we modified everything. And at least based on, kind of the post IVUS for the diagonal, it came out to be 98% expansion, just, after all the modification. And here's the run. I mean,
Great.
And the LED should be coming in. Right there. And, the bifurcation looks great. And, the LED, I think with a 1-to-1 size Wolverine and NC, I mean, it looks a lot better from an expansion standpoint. Here's the
Yeah,
LED IVUS.
you fixed the undersizing, which is nice. I mean, your stents are
Yep.
1-to-1 size now, which is sort of the improvement. So if you drill those stents up, you can tolerate a little bit of tissue recoil because the
Yep.
entire artery is larger. So the relative effect of that recoil becomes less because you've now got 1-to-1 size stents where you didn't start that way. So it's a really nice imaging example of that product. It's great.
So yeah, so I mean, you see the stents are a lot better expanded. The Carina looks great again for the LED. And so I ended up doing kissing balloon inflation with 2-agent DCBs, so 2.5 in the Diac 3.0 in that LED, and then I took a 3.5/30 for that Prox LED, just based on imaging and sizing for 60 seconds each. And this was our final result.
Looks great. Yeah, it's a really nice use of imaging to define what the problem is, what the tissue is, apply two technologies to help address it, get a short stent to fix the gap distal to the bifurcation. I think confirm with imaging that you've got a really nice prep result, and then apply DCB to avoid restenting. It's wonderful. The thing that I think we're all cognizant of is that the residual percent diameter stenosis, at least in the prospective looks at when people fail DCBs, if you've got more than 30% diameter stenosis, you're a little less likely to remain patent with a DCB treatment for ISR. So trying to get things well expanded and get a good angiographic result seems to track with better DCB outcomes. And I think like you applied that algorithm beautifully in this case. What do you think, Evan? Would you have done anything differently?
Yeah, no, I think this is great, and just building on what you mentioned is that the benefit of serial imaging is there's very limited data on the different lesion preparation modalities. So, head to head based on the type of in-stent restenosis. So by using imaging, it's the only way to know that you've achieved what you set out to do. You modify the plaque, you have adequate expansion that you can move on to that final step. So I think very liberal use of intravascular imaging, particularly in ISR, is essential. And that's basically what with Agent in the Agent IDE trial, they had over 70% intravascular imaging there. So, to get DEB like results like Agent, it's key that you're using systematic imaging like this, where it's not just one imaging run at the beginning or one imaging run at the end, but really using it to guide your management.
Hey, Khaled, I anticipate that in Kuwait, you've probably had DCBs longer than we have. And I was interested, if you're going to try to do a DCB strategy, are there things you see on the angiogram or the IVUS that you apply in a systematic way to, hey, this isn't going to hold with a DCB, I'm going to have to restent it? Because I figured you had access to these and probably have more experience than us US colleagues have now.
Yeah, we've been using DCBs for some time, and we have both types, paclitaxel and sirolimus. Usually, ISRs, we try to go with just drug-coated balloons, but sometimes if there is a stent fracture, or you have gap like what Pratik have in his case, or if you have a new atherosclerosis and clear plaque rupture in the stent, you may have to stent that segment. Otherwise, you try to go with DCBs as much as you can. With all, plaque modification techniques, you try to use whatever is needed in a specific region. You said something very important regarding the calcification. So when you have a calcium, whether it is in the plaque inside the stent or behind the stent, usually don't stent that segment anymore.
But if you use DCB, you have to use two, because you want to use one for the diagonal, one for the LED, and it's double going to be a cost of $14,000. I don't know if the reimbursement would allow us. The beauty when we did brachytherapy is one catheter for all. If you do a combination, it's tough. I mean, I think that we have to admit that it's costly, but you cannot do it with one drug-coated balloon. You need two.
Yeah, Ron, we used brachytherapy in the 90s, and then for some reason, and because of the data that were weak at that time, we stopped using it I guess in 2003, and now I think we have to get it back
Yeah, we use it primarily for those who really failed DCB, failed DES, multiple, not first-time restenosis. I think DCB will take some of the role, but we would like to have it in their armamentarium. It's always helped to have it, so we are using it. Probably 150 cases a year still.
Yeah, we have about
So
the same volume run, and we're already starting to see people referred for DCB failures now for brachy, and that's going to happen in a third of cases with DCBs, the European data shows. So there's a couple comments from the chat, with regard to Wolverine and angiosculpt gimmick or value proposition in in-stent restenosis. I think, Evan, you may have mentioned, at least some preclinical studies to facilitate drug delivery. Other thoughts on these two technologies in in-stent restenosis, other than the fact that they stay put and don't watermelon seed? Do you like them in this scenario?
Yeah, I like it. But we have very limited data. It's observational data. There's some initial data, a small observational study showing with cutting balloons the impact of potentially greater drug delivery with DEBs, but we certainly don't have randomized trials looking at it. I think the reality is we don't know, and what we know is with in-stent restenosis, as Kevin mentioned, is they come back. It's a revolving door, pretty much no matter what the treatment is. Another stent, another DEB, brachytherapy, very high. Once someone's had ISR, it's tremendously high rates of recurrent stent-related events, and you just want to be as aggressive as you can each time they're in the cath lab to try to delay that next time they're there. So I think if Alex had mentioned before about why not start with an NC. I think that's appropriate. If you image it and you have great expansion plaque modification, oftentimes you can stop with an NC. But the key is you need to make sure you've really reached that endpoint. If not, I would just have a very low threshold for using specialty balloons. And even if that's not working, then for IVL and laser and sometimes mechanical atherectomy.
Yeah. Great. Well, thanks, Patrick. That was a great case. We're going to move on now to Dr. Khalid Al-Mari, who's presenting from Kuwait. Thanks for being here, Khalid. We appreciate it. Go ahead and take the form and load your slides up.
Thank you for the invitation to this meeting. And what I'm going to present is a bifurcation in-stent restenosis. So the patient is a 58 years old gentleman who had angina, and then he presented this time with angina, and his past medical history include diabetes. He is smoker, and 4 years ago he had ACS, and at that time he had PCI to the LAD and diagonal branch with DK crush technique, and he had stent from circumflex artery into the obtuse marginal branch. I'll show you the result of that procedure. So we can see the LAD diagonal bifurcation stenting on the right side, and in the circumflex. Sorry,
slide show. Please.
Sorry.
Yeah, put him in presenter mode. Thanks, Khalid.
Yeah, sure.
Perfect.
So at that time he had 3.5 stent from circumflex artery into the obtuse marginal branch, and that was the result. That was 4 years ago, and then after that, 1 year after that, he had a PCI to the circumflex artery bifurcation that we don't know the details of it, what was done, what kind of a bifurcation technique used. And now he's coming with angina and LV dysfunction, 35% ejection fraction. Treadmill test was positive. And this is his angiogram now. We can see the LAD diagonal bifurcation stenting is fine. But if we look to the ostium of the obtuse marginal branch, it's really tight. And if we look carefully to the stent enhancement, we can see lots of metal at the ostium of the obtuse marginal branch. So I'm not sure what was done. Did they crush the initial stent to the side? I'm not really sure. So we did an OCT. I'll just go back straight to the bifurcation. And so this is the stent from obtuse marginal branch, well expanded. And as we come to the ostium, we can see maybe there is some new revascularization here. And most probably this is neoatherosclerosis with some lipid deposition in that plaque. And so this is the narrowing, and this is the bifurcation. So that's what we were dealing with. And minimal luminal area was 1.6. And if we look to the stent, the stent itself is 3 millimeters, and it was 3.5, but what we measured here is 3. So what I believe here is it's combination between neoatherosclerosis and stent under expansion. The question, how to treat this?
That's great, Cal.
Shall I?
Yeah, so I think by way of summary, you've got a relatively well-expanded stent with material inside it. Is that the way you read the OCT?
Yeah, I think it's neoatherosclerosis, and the stent is not really fully expanded. It was supposed to be 3.5, but not, it is 3. So it's combination between mild underexpansion and neoatherosclerosis.
Great. And I think I was struck, I'd be interested in your thoughts, Khaled, by the volume of neoatherosclerosis. There's a lot of material inside that stent.
Yes.
Great. Evan, what do you think you do in this case?
Yeah, no, I agree. You know, predominantly neoatherosclerosis, major problem, and it's mostly non-calcified. So, you know, I think right off the bat, that kind of takes IVL off the table as or any of the atherectomy devices for appropriate lesion modification. And I would, with this, I would go with, you know, going back to the last case, you know, something like a Wolverine, sculpting, scoring, cutting balloons. I think you'd be able to get pretty significant plaque modification here because it's mostly soft plaque and really just creating the cuts, and then follow that with an NC balloon. I'd start with that, repeat imaging, and then go from there.
Yeah, and the one thing we don't talk a lot about when we review these cases is, you know, all ISR tissue is not the same. We already highlighted on the pain point of calcific neoathero. I think Khaled nicely pointed out there seems to be some lipidic stuff in there. So these are the ones which may be more sort of, I've heard you and Ziad call this more like granulation tissue, Evan. These are ones that might respond okay to ballooning as opposed to needing to be debulked in some way. And so as the neuronal tissue gets brighter and then gets more calcified, its response to balloon angioplasty seems to be less favorable. So what did you decide to do, Khaled, to deal with this?
So actually, I did exactly what we just talked about. We did cutting balloon through 0.5 by 10 to the ostium, and then followed by a high pressure balloon, 3.5 by 10 OPN balloon.
The expansion
Then I did
good.
very good here. And then I finished with kissing balloon, drug-coated balloons. Then I did imaging again. So angiographically, still there is a, you know, waste into that stent, but we did an OCT, and I'll show you the same area that we were looking at. So this is the bifurcation. If we go back to the ostium, and that's the area we're looking at. So basically, the stent became bigger, the luminal area became bigger, and you can see that new atherosclerotic plaque is ruptured now. So more lumen, bigger stent, and we had laser in the hospital. We could use it, but we were happy with this result.
Yeah, so you see what appears to be cuts from the atherotomes in the neointimal tissue. It's kind of cool, actually.
No, I think this was a culotte technique. That's why the culotte looks with a single balloon, kissing balloon, where the bifurcation looks pinched like that. And I think that's the reason why it probably Restenosis more than anything else.
So, sometimes when we do OCT after the coated balloons, we could see the drug inside the vessel. So you can see it like a bright spots on OCT. I'm not sure if any of you have seen it.
Yeah, we've been observing that as well. But here is so nicely you see those cuts, and that's what we almost every time with OCT you do cutting, scoring balloons, you see the compression of the plaque and then those nice cuts, which you know again there's no data to support this yet, but I think with increased surface area, potentially it may help efficacy with the drug-coated balloons.
Yeah,
Yeah.
someone asked a question as we're on this topic to the panelists. Will the blade of the cutting balloon get stuck inside the ISR? What's been your experience, Ron and Evan, with that? Is that a problem?
It rarely happens, but I would keep it simple. I think I like the fact that you introduced the open NC. I think we could have used it also in the prior case. It's a little bit underutilized, but it's a very powerful device if you know how to use it and on which wire use it. And it's expensive with no reimbursement, but it's a very powerful device. I don't think that in the case of lipidic plaque, you don't necessarily need a scoring balloon. You can do well with just a high pressure balloon. And one thing which was surprising for me, that when you see neoatherosclerosis, you don't see much distal embolization of the lipidic plaque, which you see in de novo. If you go after de novo lipidic content of plaque, you may see some dislodging of the lipid go downstream, but you don't see it much with neoatherosclerosis. So there is some distinction between the two. But overall, I think the approach of ballooning it with or without scoring balloon, I don't think you need one here because it's not going to be a watermelon seeding, and then followed with DCB would be the right approach.
And then the only thing I'd add is just with the OCT, you see the stent struts are nowhere near the luminal surface. So that's with no concern whatsoever that the blades would get caught in this, because the stent struts are nowhere. You see, even after plaque modification, you get nowhere close to it. And that's, Kevin mentioned in the last case, sometimes of using atherectomy off label. If you do imaging and you see there's calcium within the stent struts and there's no exposure to the stent struts, it's safe to do atherectomy, even though it's ISR. Whereas if you see it's just under expansion, there's no neointimal tissue, and it's a stent strut with calcium behind the stent strut, and all the mechanical atherectomy is going to do is just ablate the metal struts. And that's really where the imaging shows you exactly what treatments are appropriate.
I was just in Korea seeing a very interesting device. This is a high pressure cutting balloon. So not a regular cutting balloon. It also have the blades, but it also can go to high pressure. And in fact, Antonio Colombo takes the current cutting balloon also to high pressure to maximize the effect. But I think a dedicated device, this is all off label, but a dedicated device that probably will be in the use within a year. High pressure cutting balloon makes sense in situations like that.
Yeah, off-label, a Wolverine can go to 24, 25 and have a reasonably low rupture rate. They wrap very, very poorly. So if you put a guide liner down to get it in the bigger sizes, you often have to take the guide liner out with the balloon if you've overinflated it. But I agree, Ron, it can be useful in those scenarios.
So the other thing, Kevin, is the drug-coated balloon should not be used for expanding a vessel. It should be just inflated enough to touch the intima. Some people use it even to go to high pressures, and that's not the aim of using drug-coated balloon. You have to prepare the vessel with high pressure balloons before and use the drug-coated balloon just to touch the walls. And it should be your final step. You shouldn't do any more dilatation after that. That's my understanding.
Yeah.
So basically,
and there was actually a question that people ask: if you use drug-coated balloon through a bifurcation with stenting, are you scraping some of the drug, or are you scraping some of the excipient? And there was a bench testing that was done, I think published this week, showing that actually you lose very little drug by going through a bifurcation or through a striated segment. But Khaled, I agree with you 100%. Do all the vessel preparation. The drug-coated balloon is just the final touch.
Yeah, and a lot of these DCBs were inflating at 6 atmospheres. You're not going to get plaque modification there. You should never discover that the balloon's not expanding with the DCB. It's, if you do all these other plaque modification prior to, you'll know whether or not you're getting good expansion. It's just painting. It's the final coating, essentially.
There's been a couple of questions in the chat which have a common theme. The first is, if stent at the ostium is 3.0, is it safe to use a 3.5 cutting balloon? I think Khaled had made the point that he had anticipated the artery should have been 3.5, but the stent was only 3.0. And then it's been asked, how do you differentiate between stent under expansion versus positive remodeling post-stenting? Maybe I'll let you take that one, Evan. It really depends a little bit on whether you're using IVUS or OCT, and it's not a single frame you look at, you look around. But how do you determine if it's under expanded, Evan? Just from a practical, I'm using OCT, this is how we do it. I'm using IVUS, this is how we do it. Versus the stent was 3.0, it should have been 3.0, and now the media is larger because of positive remodeling happened after stenting.
Sorry, I was muted. I think from any one cross section, you just can't tell. And that's where it's key, just looking at the whole vessel pullback. IVUS has a depth advantage compared with OCT, so you can really see most of the time you'll see the true vessel size throughout. And now with deep OCT, you can often see the true vessel size. But typically it's just going distal beyond that, and you can follow that through and get the vessel sizing.
It is very simple. You just have to look at uniformic expansion across the longitudinal zone of the stent, and when you see that, you can see that it's actually underexpanded to a certain area which relate to the reference. So
Yep.
it's expanded. And usually you see calcium or the reason for underexpansion. But sometimes you see recoil of stenting because there is a push of neointima formation from the outside. So I would call it exactly under expansion. I would call it recoil, especially you may see it in ultra thin struts. And that's maybe a misnomer to call it under expansion. It was just a recoil of the tissue, of the struts because of extra struts pressure of tissue.
Yeah, so stent scaffold failure, as Ron is nicely alluding to, can be a cause of why the struts seem like they don't fit the artery size. And, we've all had cases where we got a beautiful OCT or IVUS that we did years earlier, and now the stent looks terrible. And you go back and look at your original run, and you're like, hey, I didn't do such a bad job. The stent's not doing its job holding the artery open. So Khaled, go through your, oh, sorry, Ron, go ahead.
No, I said the nice thing, they all can manage with just high pressure balloons. So it doesn't really matter. I mean, I think that, look, for me, every ISR, no matter what is the mechanism, before you apply DCB or brachytherapy, you have to end with high pressure balloon. That's like a must. And that will take care of all those concerns. And if after that you still see that it's under expansion, so you have to make sure that it's not mixed with malapposition or not up full apposition. So expansion has to be rounded and has to be symmetric across the stent longitudinal plane. Under expansion or malapposition could be mixed up with under expansion. It's completely different thing, and we don't have to try for full apposition.
Great. So Khaled, show us how things resolved.
So the minimal luminal area from 1.65 to 4.9, and the stent was expanded from 3 to 3.75. This patient came back after 3 months with atypical chest pain. So we thought, well, we'll just have a relook. You can see the angiographically from the spider view, it looks fine. Then we did an OCT. This time it's Altrione. So we have, I think, to go from here and back. So now we're coming from the OM going back to the ostium, and then we'll see how that dissection healed. And we can see this is the area that we treated. So this is the one, then see, that's the bifurcation, and this is the area that we treated. And now it healed with neointimal hyperplasia. And that's what we have. Lumen is 3.55 square millimeters. And then we did RFR, which is 0.98 after 3 months. So this lesion healed nicely here. So we left it for medical therapy, of course. Just a few points with In-Stent restenosis and bifurcation. I think knowing the technique that has been used in the past help you to plan your strategy. So then most of the times you have to maintain the same bifurcation technique that was done before by wiring both sides and finish with kissing. I think imaging is mandatory and in-stent restenosis and bifurcation to know what's the mechanism and to optimize the result and avoid additional stents and a bifurcation as much as you can.
That's great, Khalid. Any comments on that? It's been discussed a little bit so far. Thoughts, Evan, Ron, John, or Pratik?
Say definitely avoid another stents in any of ISR. I think there is no point to put another stent. I think that even for the first layer, when you're tempted to do it, you probably should have a very good reason to put another stent there, especially if you have this CB today. So I would say sometimes you need, but if you can avoid it, avoid it. The first go around should be, right now, in my perspective, POBA, vessel prep, and DCB.
Excellent.
Kevin,
Other thoughts?
get on with your case now. I mean,
Great. Yep. So thank you very much. Share my screen here. Kyle, that was great. Thank you.
Thank you.
My slides up yet? No. See them okay, Tanvir?
Yep, just non-presenter mode yet.
Great.
Yeah,
Thanks.
now it's good.
Get back real quick. Beginning here. Sorry. Bear with me. There we go. So I'll try to get through this quickly. It has a bunch of parts to it. It's an 84-year-old woman presented with an acute coronary syndrome, had a cabbage turned down because she was too frail. And this is the case I'd done 11 months earlier before her in-stent restenosis event. She had severe bifurcation left main disease and severe LED disease shown here in this right panel. The mince calcium was substantial. Delivery of equipment was quite challenging. And then this aneurysmal segment of the LED, we knew would be incredibly painful to wire. And so a little bit of, how are we going to get this done? What's the safest way? The angles here were relatively difficult. You can see it's kind of an ugly Z-bend for mechanical atherectomy. So eventually we got a SUO3, which is one of our retrograde CTO wires, to go around all those bends. It's actually a really nice wire for dealing with aneurysmal segments. And then, I think quite amazingly and somewhat irritatingly, after about 4 minutes of high-speed rotational atherectomy with a 1.5 burr, it just wouldn't cross this lesion. And at this point, with 190,000 RPMs and multiple passes on an angle, I was starting to really become concerned about the possibility of wire fracture. I was moving the wire back and forth in multiple spots, trying to avoid that, but eventually it just wouldn't go through. So, the options here are to downsize to a 1.25 burr, potentially think about switching to orbital. But eventually we just sort of called it quits and went ahead and was able to get a little bit of an expansion with a small balloon. You can see there it still has a waist in it. But eventually with a bunch of guideliner deep seating, we were able to get an IVL down and did IVIS guided DK crush to the left main, extensive stenting of the LED, got good expansion and was pretty happy with this. I'll note that there were biosteal LED and left main calcific nodules that we're seeing on the IVIS. But despite that, the stents had a little bit of a D shape to them. I just have sort of the cross section here of the final IVIS from the distal segment of the LED proximal. We had really big areas and, met the post-Excel MSAs that we would want for a patient like this. And so we were pretty happy with how things turned out. And unfortunately, she came back 11 months later with a non-STEMI. And this is the angiogram from her representation. Landed back at our hospital. And you can see she has focal in-stent restenosis in this portion down here. And there's something funny going on in the left main and LED bifurcation with the circumflex. I took a magged-in view here. And, I should know better. Anytime I sort of mag up and do another angiogram, it means I should just stop and use the imaging catheter, which eventually I did. And so effectively, in this scenario, this is the OCT of her left main to LED on the left. And this is the OCT of her left circumflex. The co-registration is not adequate, but I pulled out the frames that were important. And so as outlined, this is the patient that had calcific nodules in her left main bifurcation in both limbs. It was larger in the circumflex. And now 11 months later, in addition to having LED mid-segment ISR, she has stent failure where the nodular calcium is. And so, Evan, take a look at these. I'd love to hear your thoughts on it. I showed you my IVUS from the first case. We had great expansion. And so this is what I'm dealing with now 11 months later.
Yeah, it's so frustrating when you see this, and that's with calcific nodules. It's very common. We've seen the same thing on serial imaging. We get great final intravascular imaging. We're patting ourselves on the back, and then somewhere in the 3 to 18 months later, they come back to the lab, and the nodule's right where you left it. You have a pretty significant lesion. So I think we're still in the early stages of learning what the best approach to treat it the first time to really try to prevent it from coming back. To me here, you've proven you can deliver an imaging catheter aside from just evaluating the mechanism. I think with this calcium and the fact that you've successfully delivered OCT, my lesion modification tool would be IVL.
Yeah, that's what I thought too. The thing about this, and I always struggle, like, to Ron's earlier point, did I have stent scaffold failure? The nodule pushed my stent back in. Did I have nodular regrowth, or did I have stent fracture? Those are the three main things that are in the differential when these fail. And the hard part is because the nodular stuff grows back into the stents in a way that neither IVUS nor OCT tell you. I'm always wondering kind of, is it which of those three it is? And like, you kind of treat it the same way, but it's often a combination of both. The struts can be folded on themselves. You may fluoroscopically with stent boost or some other technology see that you have fracture, and then you've just got nodules that grow back in through the stent struts. And it's a little tough to tell. Doesn't matter so much. But the one thing, to Ron's point, and I'd be interested, this entity that I've highlighted in this bifurcation left main failure, this doesn't usually respond well to angioplasty alone. It's one of those painful bifurcation ISR scenarios where I balloon these things, they still look awful, and very reluctantly I end up needing to restent. And I'll show you how I dealt with this, but I'd really love the expert faculty's comment on restenting in this scenario or not, because that's something that I've struggled with. This is the algorithm that Evan and I developed for Optimal a couple of years ago, and it just sort of highlights the root cause with intravascular imaging. Is calcium present or not? Is the stent well expanded or not? And is there stent fracture? Are the three main questions. And then we really escalate through the therapies which have been outlined: balloons, shockwave or laser on contrast, drill out the tissue or drill out the stents with orbital rota. And at the end of the day, we want to make sure we've got good expansion. And then after that, as was highlighted by Khaled, once it is well expanded, that's when you apply some antiproliferative therapy, either drug-coated balloon or brachytherapy, as previously mentioned. And sometimes you have to restent these. And the reason why I chose this case is this is an entity where I struggle a little bit. And so, once expansion is confirmed, when do we tend to consider putting another stent in? If we have big neointimal dissections, if we have stents that won't sort of scaffold the artery, or stent fracture, those are the times when typically I'm thinking you're going to need to put a new stent in potentially. And so in this particular case, I actually staged this because we started this later in the day. I dealt with her mid-LED stent with IVL because the expansion wasn't perfect there, despite the fact it looked okay in the initial case in the IVUS I showed you. And then we just took a DCB approach. And to Ron's point earlier, this case is getting expensive already, right? It's an inpatient. I've used an IVL in the mid-LED. I'm treating the distal outflow native disease unstented with a 2.5 agent. I'm treating the mid-LED ISR with a 3.0 agent and try to save my boss a little bit money in a very off-label way. I took a 4.040 Ranger DCB, which is the peripheral DCB, and I used that for the proximal LED. And at that point, I stopped and figured I would tackle the left main, and we brought her back to do that the following day. And so I showed you what the entity was, and I think much like Evan suggested, we were able to deliver. So there is a value proposition to Shockwave with its mechanism of action, fracturing the base of these nodules and softening them back up. You could take a 2.0 rotabur and drill it out, or bi-ostial orbital. Those are reasonable for debulking, but the problem here is that you need a lot of pulses to deal with these things. So I actually used 2 4.0 IVLs, one balloon in the LED and one in the circ, because these tend to be relatively pulse intensive problems. And so with that in mind, we still had recoil of both ostia angiographically. So it wasn't ready for DCB at this point in my mind. And I ended up painfully just re-culotte stenting them with 2 Megatrons because they're high radial force stents. You can see culotting left main to LAD and left main to circumflex because the recoil was quite substantial, both angiographically and on the subsequent IVUS. And so we did IVUS guided stenting, made sure we had, post-Excel, Kang criteria, superior areas, and all this. It expanded quite nicely, but I sort of sent the poor lady home thinking, we did a reasonable job the first time. I did a reasonable job, I think, the second time. What are we left to do? So in cases like this, we'll typically try to attack the inflammatory process. We gave her silostazole and colchicine because there's a little bit of data for these drugs post-intervention targeting the inflammatory pathobiology that drives this stuff. But, this was a pain point for me because we tried to do a good job. We had ostial stent failure in both ostia related to nodules, and it wasn't responding well enough to angioplasty that I had to do this to it. And so I'd love thoughts from the team in terms of if you have any better approach to this, because I had to do exactly what I didn't want to, was re-bifurcate stent the left main.
Yeah, it's a tough one, but if you have a stent fracture, I think you're left with no more much options. You really have to re-stent it because you don't want to leave a fracture stent. Think about the mobility of the artery, the pulsatility of the artery when you have like a needle poking all the time, the neointima. This is like the epitome of a stimulation, more neointima formation. So you really don't want to be in a situation like that. So I would say that you have a stent fracture. What you really need to do, and you did it, if you IVL it, you work a little bit on the underlying cause, you may try to prevent a recurrent stent fracture. And that's probably would be the best. But I would never leave a stent fracture without another layer of stent. You have to do that. And I'm not such a big worry about multiple layers of stent obstructing the lumen. Remember, we have a lumen of about 3.5, 4.0, even a 3.0. So what is another 80 micron? I mean, it's really, people are afraid to do it, but I'm more afraid to leave a fracture stent under cover.
Yeah, and we had huge areas at the end, you can see. So I think, that part of it we covered, but then we tried to attack the inflammatory part of this. But nodular stent failure and bifurcations is a pain. They live in the circumflex, and they're one of the main reasons that we see our left main bifurcation PCIs come back with stent failure.
You guys
But,
think
but Kevin, I'll tell you what I will do with this patient. Hold on just 1 second, Evan. I would bring this patient in 3 months to a surveillance angiogram and imaging. And if I see that there is some tissue progressing into this area, I would add brachytherapy to this vessel because I think that just doing it and waiting for luck, it's too much. I mean, you really need to look at those patients probably in a surveillance between 3 to 4 months before they develop situation that you won't be able to treat. So brachytherapy, not immediately, but in 3-4 months probably would be advisable here.
Yeah, and we, Ron, for some of our more calcitrant patients, have been taking to both DCBing and repeat braking if there were prior brachy failure, because these poor people just keep coming back and back. And at least in our experience, we had no hazard of that. So
we did up to 3 times with no hazard, as long as there is a 1-year interval between the two.
Yep, us too. We see a lot of those. Devin, you were going to say something?
Yeah, I was just going to ask the panel, what you guys thought, any role of different strut, either thicker strut scaffold or something more supportive? So, some thought of potentially like a Megatron for these calcific nodules, perhaps to prevent some of that potential recoil that you're seeing.
Yeah, I won't use a thin strut stent in nodular calcium, and that's why I chose Megatrons to retreat. As the buttressing capacity is touted to be superior.
Yeah, and I'm glad that you brought up that pharmacotherapy. I think pharmacotherapy is critical here, and I would just go beyond. There was a question about P2Y12 non-responders. With the imaging, if you see there's no thrombus, I don't think that's really the driving factor here. But anytime I see neoatherosclerosis with in-stent restenosis, I'm very aggressive with getting that LDL below 55. Very liberal use of PCSK9 inhibitors.
Yep.
In addition to the anti-inflammatory meds that Kevin talked about.
Great. So we've got about 2 minutes left. We're just going to let John Liskier talk about the Emory setup. They've actually been so in on this problem to help patients, and they've started a brachytherapy program over the past year, which has gotten very busy very quickly, John. So tell us a little bit about your stent failure practice, the clinic you have, and your efforts to help these patients.
Yeah, thanks so much to everybody for the invitation, and thanks, Kevin. He's been a huge mentor in this whole process. So, as everyone has already alluded to on the panel, stent failure is such a large problem, especially in our part of the country in the Southeast, and there's not a lot of comprehensive stent failure management programs. So, Prathik Sandasara really led the effort, and then I joined him when I started on faculty. So, we have a dedicated stent failure program with 2 MDs, Prathik and myself, a dedicated coordinator that really assists us getting these patients in, getting the films, and all the almost unbelievable amount of back work it takes to get them approved. We've had a significant amount of education with our APP staff, especially with the pharmacotherapy and doing things like getting these people on, uninterrupted DAPT and colchicine, and then really have tried to offer more so than, the brachy clinic, a comprehensive stent failure management clinic, be it either brachytherapy, drug-coated balloon therapy, or we have a surgeon here, John Puskas, who in very extreme cases will actually do stentectomy and cut out the stents and reconstruct the artery. We've made a big effort to standardize our practices, so it's almost kind of akin to the CTO world, the way we do things with 100% of intravascular imaging and the algorithmic approach that you and Evan were so instrumental in developing. We then have long-term follow-up on all these patients. We put them in an in-house registry with the hope of being able to generate some meaningful data going forward about imaging and the approach and long-term outcomes. And we started back in July, Kevin, I think is when you came down for the first time. And we've done about 129 cases to date. So we're very grateful for all your help and certainly look forward to keep going.
Great. Yeah, I know for people that are looking to grow their practice, I mean, it really is an underserved area for which there's a lot of camaraderie and shared approaches and algorithms. And, I credit Ron to helping teach all of us the importance of this field and the various ways to treat it over years. He's been at this a long time, and it is a little bit of a Sisyphean task, Ron. For some of these patients, you feel like you're eternally rolling the rock up the hill, but they definitely need our services. And, they may be back every couple of years, but we keep them going to the best of our ability. There was one last question about the medical therapy that Evan, spoke further about. How long do you leave people on colchicine and xylostazol? There's not a lot of clarity. I took coaching from our cardio room clinic where they put their patients that are highly inflamed on colchicine for life. It's the Colcott dosing. I had the reference on that slide. We give people 0.6 milligrams Q day. I think Lodoco is 0.5. It's more expensive, so we just give them generic colchicine as long as they can tolerate it. And in the Q day dosing, it tends to be well tolerated. And I put people on xylostazol for 18 months, not knowing any better. I don't know, John or Pratik or Evan, if you do anything differently for these chronic in-stent restenosis patients.
I would say in the past we used to give oral sirolimus, but it was associated with a lot of side effects, so we stopped doing that. I would not give colchicine if you don't have high CRP, because the inflammatory process, if it's very local, it's going to be very hard to believe that colchicine will do anything to the local inflammation, which could be resulted from the polymer or from something else. So you need to have more systematic CRP levels or something that would be, because there are side effects with colchicine. It's not that it's not that innocent. So, and not everybody can take it also. So I really think that brachytherapy for me is like the sledgehammer for everything. It's not a permanent solution, but at least it gives you some relief. And as we said, you can do it 2 or 3 times. And the surgery is also an option. Sometimes that's the only option. So we just trying to avoid it, but we have to admit that if this is an LAD like this patient that you showed, Kevin, you can easily graft this and patient probably would live longer and good quality of life.
Right. Yeah, I wish our surgeons would have taken her up front because it would have saved us these complicated procedures. Well, Tanvir, thank you very much for organizing this tonight. I want to thank our co-moderator, Juan Waxman, Khalid, Evan, John, Pratik, presenters, and panelists. This has really been wonderful. I think it nicely highlights an extension of interest in bifurcation. Bifurcation PCI is interesting because it's complicated. There's ways to do it well, and they're more TLR failure prone. And so, when they fail, I think it's an added benefit to have a systematic approach to treat them. So, Tanvir, any final thoughts before we wrap up? Great. All right. Well, thanks, everyone. I hope you have a good night. We appreciate all the attendees.
Yeah, thank you for moderating.
You will. Take care.
Thank you.